Good afternoon. We have the great privilege of having Mr. Craig for a second presentation today. I'll quickly introduce him and he will continue with his beautiful presentation. We'll try to keep a short period for Q&A at the end if we have time. Dr. Campbell is VP of Pediatrics Department and Research, Neurology and Pediatry, and Director of Multidisciplinary in the London Health Sciences Centre. He's a professor in pediatrics, neurology, epidemiology in Western University, and scientific in Children's Health Research Institute. He completed his pediatric degree at University of Ottawa. Among his university activities, as mentioned, clinical research with Duchenne syndrome. He's part of many clinical trials in neuromuscular pediatric diseases from the university and industry. He's part of the Muscle Study Group, World Muscle Society, and co-chair the Supervision Committee Treat MND for neuromuscular diseases. It's finally dystrophy muscle. Gave twice the award George Capati in 2011 and 2015. The presentation will be done in English.
Really appreciate the opportunity to be here and to be able to talk a little bit about, well, earlier today Duchenne and now myotonic dystrophy. I apologize, the title in your programs is not exactly what I was going to focus on. So if you, so I'm really going to focus down on congenital myotonic dystrophy. So if you wish to leave now, make a quick exit. And I'm going to take inspiration on this talk from a paper we wrote a couple of years ago with Dr. Kam-Tu Nguyen, who I had the great pleasure to work with for a year as a neuromuscular fellow, and so she's been a part of a lot of this work, and I'm going to mention her name through here as well. This article focused on myotonic dystrophy in general. I have a number of disclosures with industry. I'm happy to discuss them further if people want me to hear about that. So myotonic dystrophy, I'm not going to really go in a great detail into the disease. I think it's well known for everyone in the room. This is myotonic dystrophy is part of a group of multi-system dystrophic myotonic disorders, and I'm going to focus primarily on DM1. Which is a CTG trinucleotide repeat disorder in the DMPK gene, but there is another form of myotonic dystrophy called type 2, and it's in a different gene loci, but it shares with DM1 being a nucleotide repeat disorder. In this case, it's a tetranucleotide repeat disorder, and I'm going to show you why that becomes critical to understanding the pathophysiology. So congenital myotonic dystrophy is the most severe form of myotonic dystrophy type 1. So I just want to get that clear. Within myotonic dystrophy type 1, there's a spectrum of severity, and congenital myotonic dystrophy is the most severe type. And these are kids who are born usually prematurely. They often even have signs that the pregnancy isn't quite going right in utero, but they have low APGAR scores, often mechanical respiratory failure, so they need ventilation support, increased secretions, GI dysfunction. And I've shown some pictures here. You can clearly see the facial weakness, ptosis, hypotonia, and weakness, the hyporeflexia, often multiple joint contractures, undescended testes, generalized edema, and they often have a large head size and ventriculomegaly. But in contrast to most forms of myotonic dystrophy, babies and children do not yet have the myotonia, and I maybe touch back on that, but this is a different disorder than the adult form in its pathophysiology, and so the myotonia hasn't necessarily yet developed. As I mentioned, it's a very unique disorder genetically. the trinucleotide repeat is actually in a region of the gene that's not even transcribed. So what happens is this extra genetic material that's sitting there gets all clumped up in the nucleus, and I, the first thought was, oh, maybe this is going to be toxic to the cell, but it's actually not. So those are some pictures of these nuclear clumps. What it actually does is affect these RNA binding proteins, self and muscle blind. And those RNA binding proteins get all mixed up because of this toxic accumulation. And those RNA binding proteins are involved in all sorts of different regulation, splicing regulation in the body. And that's why myotonic dystrophy is a multi-system disorder. There's very many manifestations of it. Even though we tend to think of it as a muscle problem, it is in fact not so much. And even more specifically, what happens with these two RNA binding proteins is one gets down-regulated and stuck in these clumps, and the other gets effectively upregulated. I've put this little sidebar here because self and GSK3 beta have a very unique relationship, and it appears that GSK3 beta gets increased because of this increased activity, and there may actually be a sort of a negative feedback loop here, or I guess actually probably more accurately a positive feedback loop where this can be a bit self-perpetuating, and the effects of GSK3 beta have some other effects on degeneration of the muscle cell, and lack of maturity of the muscle cell. But basically what this new dynamic does is it switches splicing patterns in all tissues, and what it does is force the splicing patterns more to an immature form of various different protein isoforms versus the mature form. And so basically what you end up with, largely for the congenital form, is almost an exaggerated immaturity of muscle. And in fact, as anyone will know who treats these kids get stronger over time. So compared to or relative to other congenital muscle diseases, if you can wait it out, things will go okay. So my 5 things, we're going to talk about definition here a little bit, then some clinical aspects, care guidelines, outcome measures, and novel therapies. I'm just going to spend just a minute on each, but I just want to give you a flavor of what some of the current issues are in the field. I don't think it will be lost on anyone that issues of definition and classification are critical. How do we prognosticate for families? Is it based on severity, based on trinucleotide repeat? Are we saying the same thing when we call something congenital myotonic dystrophy? And how do we structure our research protocols around classification when really at this point in time we're in a bit of a disarray in the field? Clearly we can't use CTG repeat size, and that's been well documented that there's so much variability. So on the bottom panel you can see the repeat size in the congenital form, and although they're very expanded compared to classic adult onset or minimal disease, you can still see quite a bit of overlap. So there's no way to sort of classify someone as congenital based on the repeat size, nor should you. That's been very clear. So what's happened is that there's been a traditional definition that's been defined as calling something congenital if the child has symptoms between 0 and 1 years of age, childhood if it's 1 to 10, and juvenile 11 to 20. These are completely arbitrary. We have no real good understanding of what happens at those cut points other than I presume these were just judgment calls by people in the past. But they present problems for us because, in fact, people who have a family history will be suspicious of their child's symptoms very early on versus families who don't. And in fact, about half the children are the index case for the family. So you've got half the people sort of aware and looking for signs and symptoms in the first year of life, and half who don't. So that's a problem. Second, we now have genetic testing, and that's really helped us define, because there was often kids lumped in together with congenital muscle disease. It's quite clear that we've just finished, we have a paper in press where we've gone back and looked in the literature at case series, and we really have a mishmash of people using this definition versus other definitions. And of course, even just from a nomenclature point of view, we don't typically talk about something as congenital up to 1 year of age. So this traditional definition is of some concern. And basically what we've ended up proposing is that if you have congenital myotonic dystrophy, you have to have symptoms right away in the neonatal period, and they have to be severe enough to actually have some symptoms or problems or require some medical attention. And so here's what we've proposed. Again, these need to be vetted in the community and discussed, but this is what we've been using, that really congenital DM should be a very specific thing, so we can give families a sense of prognostication based on an actual set of criteria, and we can use in the literature a very clear objective definition, and then we'd call everything else in the pediatric age range childhood DM. I do not see why an arbitrary set period of 10 years old becomes a distinction. In fact, most families cannot fit that into a clear onset of symptoms. And then, of course, fetal tissue should not be called congenital DM because those kids haven't even been born yet. But when you're in many research meetings, people will call expanded CTG repeat size in fetal tissue congenital myotonic dystrophy, and that is absolutely not the case. We may now have a biomarker, and I'm not going to go into this in great detail, but I will. This is from Chris Pearson's lab in Toronto, a very critical paper for our field, where basically he looked in this, you can see in this middle panel, he looked at methylation patterns upstream and downstream from the CTG repeat, and the one thing that distinguishes the congenital forms from classic DM1 and DM1 cell lines, as well as CVS samples and other fetal tissue, was this very prominent methylation, and those markers indicate that there's an epigenetic phenomena going on here, and this needs validation and more exploration, but this may be the biomarker we've been looking for to say someone has congenital myotonic dystrophy. Just going to touch quickly on clinical care guidelines. These care guidelines have been an international effort to create they're not evidence-based. There's very little literature, to be honest, around congenital myotonic dystrophy, but we tried to do a clinical care guideline, a consensus-based statement with people all over the world of various expertise, and these should be submitted shortly. The adult care guidelines have been submitted to neurology clinical care, I believe. And so people should be on the lookout for these coming down the pipeline. And they go into this kind of format. I'm not going to go into this in great detail, but basically have a very accessible look to them. They have a background, some recommendations, and then most of the sections have a focus on congenital myotonic dystrophy, given that it is such a unique and usually focal point for decisions around management. So that's how we've structured them. They address 10 different body systems, 5 different care scenarios. They're multidisciplinary, family-centered care. We talk about genetic counseling throughout them, and really being proactive and engaged in healthcare monitoring. I should mention that Cynthia Gagnon was critical in moving forward the adult care guidelines, and I've been lucky to be involved in the pediatric, well, in both versions, to be honest, but the pediatric version. So I just want to touch quickly on autistic features and social communication. Autistic features have been a controversial aspect of congenital myotonic dystrophy, and we're not going to solve that here today. But I do want to just point out that many people with myotonic dystrophy, childhood and congenital, are said to have autistic features. And it's created some concern for families, some controversy for us in the clinical community. What we're clearly seeing, and this comes from data that we've done where we administer an autism spectrum severity score that I'm showing you on the bottom. Certainly what happens, and you can think to kids you've seen with congenital myotonic dystrophy, what happens is on standardized scores for autism, they score quite high. The cutoff here is about 13 for a clinical concern, and these kids are scoring up around 17. But I'm not really sure that we should truly call this autism in my mind. And I just point you to a very recent, in just the last journal of neuromuscular disorder, Natalie Angard, who's part of our care considerations, a good colleague of mine, has done a really nice article comparing some of the features of autistic spectrum disorder to congenital and childhood onset myotonic dystrophy. And there really is quite significant differences in the social, language, cognition, brain organization of these two disorders. And I think this conversation needs to continue to happen. But I'll be honest, in my opinion, I think calling these more of a social communication disorder is probably more appropriate in my mind. So let's talk about outcome measures and sort of getting organized. We have a well-run national neuromuscular disease registry here in Canada. I want people to be aware of that. We have 27 clinics in 8 provinces, over 3,000 patients registered in the registry, adult and children. And here's some of the breakdown of different things, but myotonic dystrophy is, I think, this one up here. And I do want to note that Cam Tu Nguyen, who's in Montreal at Saint Justine, will be the new DM1 working group lead for our Canadian efforts in myotonic dystrophy. This is a very important resource as we collaborate on research and plan for clinical trials and various other educational and advocacy issues. We're also part of the Treat NMD Global network, and the DM1 working group lead for that is Richard Roxborough from New Zealand, and we have over 10,000 myotonic dystrophy patients captured in that network, and you can see the map of all the DM1 registries here in the middle that are under our umbrella, and I'm currently the chair-elect for that group. The other thing, I just wanted to highlight this work because it's good stuff that Cam Tu Nguyen is doing, and we've been looking at, how do you describe, what's the phenotype of congenital myotonic dystrophy? Can we use more objective terminology? And so this little project was looking at using HPO ontology system with the phenotypes and phenostacks program. And what you can do here is with all these phenotypic traits on the side, you can map these across in a visual way. And here we've got the patients sorted by repeat size. Very neat tool just to look at different phenotypic features and whether they vary by markers of disease severity. So, are we prepared for novel clinical trials? Not really. We don't really have a lot of validated outcome measures yet. I think we're still struggling to know the natural history, and certainly measuring treatment effect. We've got a lot of work to do, but we've been working hard on this, and we're started with a study called Help CDM. We've now moved into a second phase called Treat CDM with Nick Johnson in Utah and Valeria Sansoni in Milan. We have 50 children enrolled, as well as some additional control patients. And we're looking at objective and trying to validate outcome measures in 7 different domains. And I won't go through all the details, but we've looked at patient-reported outcomes, so sleep, fatigue, health-related quality of life, and done work in looking at those outcomes. And these all basically show sort of on this panel patients with CDM and controls, and on sleep, different sleep parameters, and on quality of life. You can see the difference down here in quality of life between controls and patients with CDM, and here's divided by repeat size. But basically we're trying to accumulate this data so that we can use them in the clinical trial setting. Same with different biomarkers. We're looking at DEXA. Because this is a disease of muscle immaturity, our hypothesis that is, as the kids age, their lean body mass will get closer to their age-matched Z scores, and that's what you can see here, although again, I recognize the variability is high. This links to different motor functions that you can do, the DEXA scanning, and we've published this or presented this. One of the real important measures that we're looking at is oral strength, and you can see on the top panel the difference between the oral strength in patients with myotonic dystrophy here versus controls, and that's really a nice distinction, no overlap here. And then this is just brand new data that we presented at the AAN last week, showing the change in lip force over a 12-month time period. These are all individual patients, and really other than a few outliers that really seem to take off, and I'm not sure that these to me don't seem valid, but this looks like actually a good stable outcome measure that we might be, if we had a treatment that was effective, we may be able to see, what's happening more clearly here, say as opposed to this data is on the 6-minute walk test. You can see kids are all over the map here, and this would not be a good outcome measure for a 1-year trial, even though it segregates nicely by controls and patients. So these are the kinds of things we're grappling with as we move to try and understand clinical trials. And so I'll just my last, 5th point is recognizing that there are pathways that we can exploit here to try and improve this pathophysiologic process in myotonic dystrophy. There's a number of companies and academic labs that have looked at antisense silencing of the DMPK transcript. Unfortunately, the group that was furthest ahead on this, Ionis and Biogen, we didn't get good tissue penetration, and that trial has been stopped. They're going back to next generation. But there are other pathways. One of the things we're looking at is this issue of increased GSK3 beta, because there are GSK3 beta inhibitors that are available in the clinical realm and have actually been trialed in autism and dementia. And so we were looking at this and focusing on a drug called titaglusib, which has made it into clinical trials. But this is a ubiquitous kinase that has a role in organogenesis, brain development, muscle development, and so it had some attraction. And in preclinical work, this is lots of work done by a colleague at Cincinnati Children's Hospital, Luba Timchenko, and her various students, basically showing improved muscle histology, improved grip strength here. And in fact, I didn't show this data, but there's improved behavioral phenotype, improved growth when myotonic dystrophy cell lines, animals are treated with this, and we're hoping that that's the case when we treat patients with this. And so we're just about to start a clinical trial with titaglusib, and so we will have one site in Canada, my site in London. We're working with a few sites in the US as well. So if you have patients who might be interested in this, we'd love to have them down to London. It's an oral drug, so there's only a few visits that are required. So I hope I've just covered on some of the more critical and controversial areas and areas I think people should be aware of in this field. It's an exciting time, and I really love being a part of this work with various colleagues around the world. So, and just to acknowledge the team, and as I mentioned before, Dr. Nguyen, who was with us in London for a year and was really a valuable part of the team. Great to see her here today. So thanks very much.
Hi, I'm Lisa Corbet, a physiotherapist in London at the Thames Valley Children's Centre. I just have a question of when, because I had followed a little one until she was 4 before she went into school-age therapy, and they still have the low tone. When do they start to have the myotonias, or the increased
That's a good question.
muscle tone?
So that's one of the objectives of our studies, our long-term outcome studies, is really to try and see where the children go from their improved muscle tone and strength. And I didn't even present much of this data, but there's it is very clear that things do get better for them over time. We're starting to see maybe an inflection point around age 10 from the data, but I mean, obviously every individual's different, but it's probably around there. We see a stabilization of some of the motor tests, and again, we're seeing that a little bit in the long-term data, and then probably those kids will go into a more degenerative, like more the adult type, more of a degenerative pattern with myotonia evolving. But this is obviously something we're trying to sort out in a little more detail. So it's a very good question. There's no perfect answer for that right now. Thank you.